when you order a test, make sure in your own mind what result you are going to expect. Most of the time you will be right. A lot of parents like to give vitamin C to improve immunity and prevent cold, etc. You can get a false negative report for occult blood, and we have to be careful because after home collection, that person will go to multiple places to do the collection, and finally the sample will reach the lab. And you know the condition of the roads everywhere in the country, and you will have excessive amount of shaking and resultant hemolysis. When an assurance is a false assurance, meaning you get a report which says normal or negative, but you may still have a problem.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So today, what we are going to focus on is pitfalls in interpretation of labs in pediatrics. What do we mean by that? Whenever we see a report, we tend to expect something out of the report when we ask for a test. And when we get the report, we are supposed to act on that report. In most circumstances, you will accept and take that report as prima facie. But we will learn today about what are the common laboratory pitfalls, most important, pediatric being the dynamic area that it is. We'll look at age-specific problems. We'll also explain what are the physiological variations and also try to learn when an assurance is a false assurance, meaning you get a report which says normal or negative, but you may still have a problem. And most importantly, we will try to cover 15 to 20 case scenarios very quickly to understand where you have to be careful before you accept the report as it has been provided to you. And this is what we talk about faults. And I know the actual spelling is different, but here what we are going to talk is what are the factors affecting laboratory tests that we need to focus on. So the most important thing is when you get a report, when will you suspect that there is a problem with this report, or that you and me are likely to make a mistake or make an error in interpreting this report? And I would say only one word for this. If you have a report that is unexpected, then please make sure that you look at various things before you say that this is what is the report and we will be accepting that report. So let us understand what are the reasons, especially in pediatrics, that one needs to be careful about. We have a very wide variation as per age. What I mean by is what is normal WBC count on day one, which could be 25,000 and completely normal, to a 10 to 15,000 WBC count in a child where you would not consider a problem. Similarly, you can have many tests for which the validation has not been done in pediatric age group, but we are simply following the adult range and we have little to do about it, only that we need to make sure it fits with our other parameters. We also have problems with sample, that means difficulty in collecting the sample, etc. We'll talk about that. Also, children usually are disease free to start with, apart from the fact that what acute condition you are managing. When we start suspecting that there is an error, obviously you want to say it's a pre-analytical error, means you and me are not responsible for it. What do you mean by that? So the common pre-analytical errors that we see are urine collection. So if the urine is not collected properly, you may get a contaminated sample, or if the secretions are not cleaned before the urine sample is collected, you may get some bacteria or some other particulate matter. And if it is not stored correctly, that means if the urine after collection was not tested immediately and was stored outside at room temperature, one could have change in the report. Transport, again, very important, because not all labs do the tests themselves, and especially certain tests, like even in hospital, if you collect the sample and it lies in the ward or in the ICU for a longer time, things like ABG, lactate, ammonia, all these are very time sensitive, temperature sensitive reports that you have to be careful about. There are some tests which we do home collection, and we have to be careful, because after doing home collection, that person will go to multiple places to do the collection, and finally the sample will reach the lab. And you know the condition of the roads everywhere in the country, and you will have excessive amount of shaking and resultant hemolysis. Also, we have to remember that some tests like prothrombin time, or for example PTH, are best tested fresh, and hence we must make an effort to send these patients to a laboratory where the tests are done there only, and not to a collection center, and definitely not for a home collection. And we know that in some conditions like cortisol, you want to make sure it's an early morning 8 o'clock sample to get the morning cortisol level. And there are some unique situations where you may ask for a midnight cortisol to make sure you are ruling out a problem related to the same. We can also have problems when the sample was collected in the wrong tube. If the sample was insufficient in a tube, for example, prothrombin time again, where the ratio of blood and the reagent was not correct, you are likely to get erroneous reports. Similarly, if there is insufficient sample in a blood culture bottle, one may not get adequate growth. And similarly, IV line collections are not encouraged, but we have to be careful about interpreting them. Next, we look at the analytical. So we have pre-analytical these problems, we have analytical problems, and then we'll have post-analytical problems. So in analytical problem, things are not much under our control. What is under our control for analytical is that we send it to the appropriate lab, a good lab which has standardization, which you know well, and most importantly, the lab with which you will be able to communicate that, oh, this report is not good. For example, we had a patient when there was an unusually high WBC count in a fever for only 2 days. And my lab called me up immediately to say, are you expecting anything? And then it turned out to be a very serious condition eventually. Let's focus on analytical errors. When you do hormone testing, if very high hormone levels are there, they will affect the immunoassay and you may get falsely low values. A good lab may do dilution and then test again if they identify this as a problem. Poor standardization and ready-to-use kits of poor quality are some of the other reasons where you may have a problem. Now we looked at the analytical problems. Let's look at some of the problems which are biological phenomena. So what do I mean by that? If there is an agglutinin present and you get rouleau formation, means the RBCs, they stick to each other, you'll get a falsely high MCV value because the whole thing will be counted as one RBC by the machine. Similarly, when there are cold agglutinins positive, many tests you might get false positive. So you need to be careful. If there is platelet agglutination, obviously you will get abnormally low platelet report, and if you are not expecting that low report, you will check with the manual count or send a repeat sample. Similarly, if there are nucleated RBCs, that is retic count is increased, or if there is hemolysis, or if the serum is lipemic, in conditions like nephrotic syndrome, familial hyperlipidemia, etc., one needs to analyze and make sure that these reports are appropriately adjusted. And then there are some physiological factors like fever. So when we say fever increased WBC count, it could be because of infection, or it could be or very high fever, febrile seizure, and it could be related to a stress response. Fever can give mild proteinuria also. Similarly, exercise can cause various changes, which like presence of proteins in the urine or sometimes increased levels of creatinine kinase and some other problems. We know that in winters you need to adjust the thyroid dosages, and puberty and stress have their own issues. And so, if you have a result which you do not expect and which does not fit with your clinical finding, make sure that you look at these possible problems. Similarly, we already discussed diurnal problems. And when you ask for a fasting report, a good fasting report will give you appropriate lipid reports and for fasting blood sugar reports. Most of us will not have this problem, but people who are practicing or who have traveled and stayed for reasonable time at altitude can have normally high hemoglobin and various other changes. And finally, post transfusion, we know that tests like hemoglobin electrophoresis or hemoglobin or blood group matching, all these can throw us out of range. Let us focus on age, which is a very important variable for pediatricians. We know that newborns have very high WBC. They also have high MCV. An MCV of 100 is normal in a newborn age, but definitely will be a pointer for megaloblastic anemia in somebody who is older. Similarly, we know that cord blood TSH is very high and then subsequently comes down. There are many drugs and antibodies which go cross placental, and when you test the newborn, sometimes you will get a reflection of the maternal levels. Usually, these things stabilize by 3 months and sometimes up to 6 months. And again, during puberty and growth of the child, you will have variable reports which you need to pay attention to. And lastly, we look at post analytical. So, what do you mean by that? Most commonly, you see a reference range which has been given. Also, do not interpret minor deviation. So, if the SGPT range is 35 and report is 42, there is no need to panic about it. Try and avoid using single values, use trends. So, whenever in doubt and there is no emergency, wait for that report, repeat it again. And then there are confounders, apart from the ones that we talked about, are malnutrition, dehydration, dengue, tuberculosis, acute infections, autoimmune diseases. All these can affect your report and throw a googly for which you have to be careful. But finally, what you and me are most concerned about is we should not ignore a clinical context, and that is the most important post analytical error that we want to avoid. So let us look at the clinical case scenarios, and what we will try to do is we will run some clinical situations and we will explain to you what to look out for. And what we are trying to do is, if you see this slide carefully, on the left hand side there is a case information, means some brief idea about the patient, and the lab report is given, will be given for every case. And then we will have a pitfall, what caution to be taken, and what is the clinical pearl for that condition. This is the format in which each case we will try and do that. In the meanwhile, and when we put the case, if you want to write the answers, write in the chat box. That way you will be committing to a problem so that you know what you are looking for. Okay. So before we start, let me just run one poll for you. Can we have the first poll, please? So you have a 6-week-old full term 3 kg who has 10 grams per dl and is asymptomatic. Somebody thought he was pale and got a blood test done. Would you start iron therapy? Would you say this is physiological normal variation? Would you put the patient for blood transfusion, or would you do a bone marrow examination? Excellent. So we have brilliant audience as usual. And yeah. So all of you decided that this is the normal variation and you will not be doing anything about it. So what do we mean by that? You have a 2-month-old child who is well appearing, hemoglobin is 10.2, where the reference range given to us was 11 to 14 grams per dl. We'll not debate whether this is right or wrong, but the problem is you should not be labeling this as anemia and starting iron, because this child is born full term and is 3 kilos, is not a preterm. So that's why this is like a nadir point where the maternal RBCs are being broken and the baby's bone marrow is taking over. So clinical pearl to learn here is age-specific norms matter more than laboratory flags. The problem is patients will come running whenever something is written in black, bold, or some of the labs give you all the abnormal reports right up front and then they start writing the normal report. Okay, let's look at the second one. You have a 3-year-old child who has fever for 2 days. He has viral symptoms, means baby is intercurrent looking normal. There are no danger signs and there is little bit of cold and cough. Parents decided to do a CBC count on day 2 of fever. WBC count showed 17,500 and showed a lymphocytic predominance. Now here what happens is commonly one would tend to start antibiotic looking at only total count. So we must remember again age wise, if there was say 65-70% lymphocytic count and the counts are below 20,000 and there are no localizing signs, there is no need to start an antibiotic, because you can monitor this child for another 48 hours, try to see if the lesion localizes by history, examination, and if required, repeat tests. So always interpret TC with differential and age, but most importantly with clinical finding. Got a cord blood test done, which believe me, for all of you who see the newborn, please make sure they have a cord blood report. If there is no cord blood report, you ask for a TSH report, unless a newborn screening has been sent. And I will repeat this, it is medico-legally important to have a TSH report either through cord blood or through newborn screening test. Now in this case, you have a TSH which is 18, so one would be worried. But when you did the clinical examination, everything was normal. There was no goiter, but mother was on thyroxine for 1 year. So the doctor thought this is like a congenital hypothyroidism and you would start treating, which would be a pitfall. So please don't do that. Cord blood TSH up to 20 is normal. If it is above 20, you repeat the T3, T4, TSH, all three together, preferably free T3, free T4 and TSH. We don't have enough time to discuss in detail why this should be done, but it should be done this way. And remember that maternal thyroid, usually Hashimoto or autoimmune thyroid, is not equal to congenital hypothyroidism for the baby. Next, we look at this child who is a neonate, who is febrile and has showing CRP which is normal on day 1, because everybody told them any child who is a neonate and has fever, please get the investigations done. Fair enough. Now CBC is equivocal. Now here it's a reverse problem. Just because the CRP is normal and counts are equivocal, you cannot rule out bacterial sepsis, because CRP may take a little while to rise. So again, remember, we are talking about a neonate and we are talking about day 1 of fever. So the clinical pearl here is all febrile newborns are to be treated as potential bacterial infection, provided you have ruled out other conditions like dehydration, over-swaddling, etc. Okay. So remember also that if you had done CRP on first day of life for whatever reason and it came high, it could be because of a birth stress, asphyxia, or many other conditions, and need not necessarily reflect infection. And of course, high CRP will not necessarily mean there is no infection or infection. So you'll need to corroborate CRP with all other factors. Now we have a creatinine report on day 1 for this infant because his creatinine showed 1.1 milligram per dl. Now we all know that creatinine reflects the muscle mass of the patient. And we know that in children, the creatinine is usually on the lower side. And so it is likely that somebody will label this as acute kidney injury and start working up the patient on that. But if there are no clinical pointers and on day 1 the creatinine is 1.1, it's most likely that it is reflected as maternal creatinine and not a baby's kidney problem. Also, we know that kidney filtration matures by day 2, day 3, and we wait for that to happen, look for the trend, and then repeat it after 48 to 72 hours. But after day 3 to day 5, any creatinine which is higher than 1 is to be taken as kidney injury. You have a 6-year-old child or say maybe 4-year-old child, purist will say PEM not above 5 years, so that's why I'm changing my thing to 4 years, who was sick and suspected of sepsis. They did the full counts, culture, urine, x-ray, along with that the biochemistry, which calcium was 7.8, and hence aggressive calcium correction was thought upon. But we have to remember that whenever the albumin is low, the total calcium may be shown as low, but ionic calcium reflects the true calcium, which is responsible for hypocalcemia. And hence an ionic calcium should be done in order to make the correct judgment about the calcium status. The same thing applies for hypoalbuminic states. If you do an anion gap for in acid blood gas, there is a calculation which you will have to apply in order to get the correct anion gap if there is hypoalbuminemia. We again look at CRP. Now other way around. This is a 5-year-old child, irritable, high fever for day 5, no localization. Hemoglobin is 10, WBC 11,000, and CRP is 6 milligram per dl. Can I have some comments on or on something on what do you think this patient has? What are the options? What are the things that you're thinking of? Okay. So here the important point that I want to raise is this CRP 6 milligram per dl is not a normal CRP. So it's very important that you look at the units. Many times you will see platelets which are reported in thousands and some where they are reported as millions. Similarly, CRP milligram per dl is also can be reported as milligram per liter, and so this becomes a report of 60. Okay, so make sure that this is, don't take this as normal, look at milligram per dl or milligram per liter. This is equivalent to 60 milligrams per liter, and your CRP, you must also think about conditions like Kawasaki, where it may not be an infection, but CRP will be the one to rise first, and then you will have to do ESR and maybe look for other signs of Kawasaki, and maybe even do an echo, treat it like an incomplete Kawasaki. Also, the other way around, many times you will have a child with high fever, and we have had epidemics last couple of years where you have a child who is high fever for day 4, day 5, develops a rash, maybe some loose motions or red eyes, do a CRP which is very high, and you start thinking in terms of you started antibiotics but there is no response. So here is where you will also think about adenovirus, which comes with high CRP, and also other autoimmune conditions except for SLE. So to repeat, what I'm saying is make sure when you read the CRP report that the unit is mentioned and interpret accordingly. So you know it is normal or abnormal. And you look at whether this is a viral infection, bacterial infection, or an autoimmune or inflammatory condition. We have a 13-year-old child whose alkaline phosphatase is 650. Do not start thinking in terms of liver disease and start working on it, because just like in a growing child, first few years of life, alkaline phosphatase with vitamin D deficiency can be on the higher side. During puberty also one may get increased ALP, and here to look for other clinical parameters, and also if there is suspicion, look at other liver parameters, especially GGTP, before we jump onto a diagnosis of liver disease. Let's look at urine report. Now this is one of the very important thing because we routinely do this often. And you may get, I'm written all the three things positive, but I'm trying to say that some report will have occult blood positive, some will have urine 2 plus, and sometimes you will see ketones 2 plus. So what do? Do not investigate further. First pause and think where this is coming from, and look at physiological factors. So severe extreme exercise can occasionally have occult blood. Of course, contamination with menstruation or whether any local preputial injury can have occult blood positive. One could have proteins present because of very high fever or exercise or even conditions like orthostatic proteinuria. Ketones 2 plus, if there are no sugars present in the urine and you are not suspecting hyperglycemia, it's most commonly due to fasting. That means lack of calories. The child is very sick, is vomiting, not drinking, not having enough calories going in, you'll get ketones 2 plus. So no need to think of DKA suddenly that you see every urine report with ketones positive. Here a word of caution, a patient who is on vitamin C, nowadays lot of parents like to give vitamin C to improve immunity and prevent cold, etc. You can get a false negative report for occult blood. I will repeat, if the patient is on high dose vitamin C, it may mask the test for occult blood positive. You must also make sure whether this test for sugar, for example, if you are doing in babies, whether it was done with Benedict's method or whether it was done with a dipstick method. So when you see a urine report, which you see so many times, when to not trust a urine report? If the urine sample was kept for a long time, if the sample was collected in a urine bag, if there was menstrual or vaginal contamination, if it was collected after IV fluids or diuretics, especially if you are looking at urinary electrolytes, etc., or if there is dipstick and microscopy discrepancy. So if you get a dipstick positive for blood but no RBCs on microscopy, think about conditions like hemoglobinuria or myoglobinuria. Let's look at one more case scenario here. You have a child who is sick, who had febrile seizures, and as you know, any child who comes into the emergency room with seizures, we like to check for the sugars. And the sugars came as 190. So don't rush and label this as IDDM or type 1 diabetes. This is likely to be stress hyperglycemia. And so after you treat the patient, you can repeat the sample and make sure that the blood sugar is under control. So in stress situations, one can get elevated WBC count, can get elevated sugars, and sometimes changes in, if the sick patient is there, even in what we know as euthyroid 6 syndrome. Now we are looking at a child who actually came with polyuria, polydipsia, and was acidotic. Blood sugar came 550. Now you're not going to doubt this as stress report for sure. and the sodium was 110, pH was 6.9. He was rushed to the ICU, and the treatment was started. Now, what is the problem? Problem is, if you take 110 as the actual sodium and try to do the correction, that would be wrong. This is a pseudo hyponatremia, and the clinical pearl here is you must always correct the sodium for sugar, rise in the sugar, and do appropriate correction. That means for every rise in about rise of 100 milligram of sugar of glucose, you have to decrease the sodium decreases by 1.6 to 2 milliequivalent. So you have to make sure that that much sodium, less sodium correction has to be done. This 14-year-old boy went on a camping trip, had vomiting and mild jaundice. Parents suspected that they've eaten outside food, water, etc., and has got now jaundice. When you examine, liver was not palpable. Bilirubin reported was 3.6. It was unconjugated, and SGOT, and other reports were normal. Here again, do not make the mistake of saying that this is early viral hepatitis and you have got only jaundice, but liver enzymes are not elevated. Remember, in viral hepatitis, enzymes start going up first and jaundice comes up a little later or even simultaneously. So normal enzymes look for non-hepatic causes, which could be any hemolysis in the body, or here in this case, this is likely to be a Gilbert syndrome, which is much more common than what you and me think. And most likely, if you ask history, there is a very high chance that somebody in the family also has a similar condition, which may or may not have been picked up, but mild jaundice has been persisting. Okay. Now, many times now we have seen nowadays in nurseries and young children, there is a tendency to get iron studies done or getting a ferritin done to see any occult iron deficiency anemia. Now, this child had FEVC was done and decided ferritin also so that we know if there was any occult iron deficiency anemia. But here what happened? Ferritin came 350. So they said there is no iron deficiency anemia because ferritin is normal. But one must remember that ferritin is an acute phase reactant, and hence even in presence of iron deficiency anemia, if there was infection, ferritin is not the marker to be used to diagnose iron deficiency or rule out iron deficiency anemia. And so you must look at other indices or repeat once the infection is taken care. You have a 1-year-old child who has had fever for 2 days, a CBC showing 6 grams of hemoglobin, MCV of 50, 8,500 WBC. There is no liver, no spleen, and one starts to panic, saying either I'm dealing with something very serious like a systemic onset JIA or some other thrombotic condition or some other problem. But here again, we must remember that this is an unexpected result. So whenever there is an unexpected result, you always try to make sure. One second, sorry. You always try to make sure that this is not due to any lab error. So what happens is many machines, they count platelets as acellular cells. That means any cell which has no RBCs and which is smaller than a particular cutoff counted as a platelet. So the very small RBCs, when they are very small, they go into the range of platelets and they have no nuclei. So without nuclei, small RBCs will be counted as platelets and you will get very, very high platelet count. All you have to do is ask for a manual count or go for a newer machine. Also, if you see here, if you see the histogram, then you will be able to make out that there is a very long tail for very small RBCs. If you see high platelets, I would put it this way. Normally you see 1.5 to 2.5. If you saw 2.5, 3, 3.5, you are still thinking in terms of probably acute phase reactant, which could be secondary to viral infection or bacterial infection, or even because of iron deficiency anemia, one can get higher platelets because the stimulation is there to produce RBCs, along with that the platelets also get produced. If there is 4 lakhs, 5 lakhs, you're thinking in terms of Kawasaki. If it's even more and there is a long, prolonged history of fever and joint pain, etc., you're thinking of systemic onset JIA. But anything more than that, please, and no other clinical pointers, think about lab errors. Now let's come to urine culture, and there's a long discussion on this. We will make it very, very short. This is going to be a bit controversial, but please hear me out. A 2-year-old child comes with fever. Urine routine shows 4 to 5 WBC, 15 to 20 bacteria. I get the message on phone. I reply normal. Immediately the parent asks, what about the 15 to 20 bacteria? And I have to again say normal. After 48 hours, urine culture comes, shows E. coli. Now what do I do? Here the pitfall is to diagnose this as urinary tract infection, because you must remember this is most likely contamination. For all practical purposes, without risk factors, for UTI one has to have symptoms which may include fever alone, pyuria, that means WBCs in the urine routine, and culture showing urinary culture. Here, if the patient has taken antibiotics, probably without culture, just symptoms plus pyuria, I may think of UTI. The problem is, if you have only symptoms of fever, for example, and there are pus cells and culture doesn't grow anything, you may still have to look at conditions like sterile pyuria and antibiotic use. So one needs to differentiate between the two. Now you have this classic history of an infant, well grown, trying to get an IV line. He's crying, agitated, difficult blood collection. Potassium reported as 6.4. So here clearly, do not treat that as hyperkalemia. Look at sample if possible, or call up the lab and ask whether the sample was hemolyzed, whether there was any traces of water in the tube, or any vigorous shake, or prolonged time before the sample was analyzed. All these can increase hemolysis in the blood sample. Sorry. Yeah, one more patient here. Both parents have thalassemia minor or thalassemia trait. Child was also noticed to have pallor, and a hemoglobin with electrophoresis was asked. Hemoglobin here was 9, MCV was 68, so there was microcytosis, and HbA2 was reported as 3.2. So everybody was happy. Thal minor ruled out. This is iron deficiency anemia. But the caution here is severe iron deficiency anemia also lowers HbA2 and may give a false negative report for Thal minor. So what happens here is, if you accept this report, for life you will say this patient does not have thalassemia minor, and you will only treat with iron, not have a full response, only partial response, and then you will be looking for other causes. On the other hand, if you treated IDA and repeated electrophoresis, probably you will get an HbA2 higher than 3.5. Just another note to this is megaloblastic anemia can give false elevation of HbA2, and you can get a false positive Thal minor report, which again you may want to treat and reconsider. Package tests are the fashion or the flavor of the time. And 10-year-old investigated for IDA comes with this HbA report of 6.2, and all the hell's broken loose in the family because father also has type 2 diabetes. So they are thinking this 10-year-old has early onset type 2 if there's a situation. Okay. And the problem here is somebody would diagnose this as diabetes. A word of caution here, just like we said that anemia, iron deficiency anemia can affect the HbA2 for thalassemia report. In iron deficiency anemia, the RBCs tend to survive for a longer period of time, and that causes accumulation of HbA1c values by 0.5 to 1%. And again, on the other hand, in hemolytic anemia, because the lifespan is shorter, you may get falsely low HbA1c report. So you must rule out diabetes with other reports and treat HIDA and then repeat HbA1c. What we are trying to say is, if you get a report which you don't expect, please don't jump on it. Make sure that you have clinical information, and this is most applicable to package tests. We all have had cases where CA125 has come positive, somebody's PSA report has come positive, or somebody's lipids have come sky high for no rhyme or reason. And then the repeat test just shows that it was normal. We have two more cases to go. So severe unexpected high WBC count. Now here you have a 5-month-old child with fever for 2 days, pallor, but has significant hepatomegaly. Hemoglobin is only 5 and MCV 58. WBC is 60,000 and platelets 1,80,000. So somebody thought that this is two cell line affected. Platelets are low, HB is 5 and WBC is very high. So you are probably dealing with something very sinister like leukemia. But here, before you diagnose ALL, sepsis, etc. in the form of 60,000 WBCs, you have to make sure that just like non-nucleated cells are counted as RBC and platelets, the nucleated cells are counted as WBCs. So when there is anemia and there is a rapid throw of RBCs from the bone marrow, you will have higher retic count. And when you have higher retic count, they will get counted as WBCs, and sometimes you can have a falsely elevated WBC report. So this is most likely a thalassemia major patient. Check the retic count and use corrected WBC count for assessment. Here important to know that this was unexpected WBC count and the child does not fit into anything else, and so you will label this as false positive and look for causes for the same. Lastly, we have this child, 10-year-old girl with mild fever for 1 week, cough on and off, and no other signs of systemic disease. ANA came positive. Again, everybody started wondering, 1 week of fever, so likely to be SLE, girl child, 10-year-old. But we must remember that normal population can have 5 to 10% ANA positivity. Now, just like as we said about analytical errors, we have to remember that when you ask for ANA, always ask for IFA, which is a gold standard, and not do an ELISA test, because you get very higher chance of false positives. And also, before you label it as SLE, we can examine the patient again and send for other confirmatory tests like dsDNA, etc. Right? So we have now looked at 20 cases, and we have looked at some of the reasons for pre-analytical, analytical, physiological problems, and biological phenomena. There are some special situations which causes changes in multiple parameters, and let's quickly look at them. So if there is lipemic serum, as we said, be that in children with nephrotic syndrome or in adolescents with hypertriglyceridemia, or somebody who has been on TPN, or somebody has been given a lipid IV and then a sample has been collected quickly. So you may get a falsely elevated triglycerides, cholesterols, and CRP. but you may get falsely low sodium, potassium, and calcium. If there has been a hemolysis, you are likely to get high potassium, high LDH, and high SGOT, but you may get low calcium or low hepatoglobin. In case of hyperglycemia, of course, the osmolality will go up. Triglycerides may also falsely be elevated, but sodium is likely to be reported lower than what it actually is. We already discussed that infection from point of view of anemia will give you wrong information of ferritin, but infection may also cause transient drop in albumin and iron. And exercise causes falsely elevated WBC report, CK, that is creatinine kinase, and lactate. When I say falsely elevated means they are elevated because of excessive exercise, but that means that we need to take exercise as the cause and not consider them as a disease problem, is what we are trying to emphasize. Okay. So finally, let us recap what we have said so far in next 5 minutes. Age specific reference ranges are extremely important. Try not to treat a number. Whenever in doubt, look at the trend. So don't hesitate and repeat a test. Depending upon the urgency or emergency, you can repeat the test appropriately. So if you have a sugar which is very high and you are thinking of stress, you may repeat it after few hours. But if you have a thyroid report which looks like a euthyroid, then you may repeat it after a few days or weeks. A single value can be misleading, so try to see previous reports of the same patients or try to look at subsequent reports as we discussed. Always look for pre-analytical errors. Believe me, they are much more common than what we think they are. And a normal value does not always mean a normal child, and a normal child will not necessarily have a normal value. Acute illness distorts lab results, as we already discussed in the physiological phenomena. Use reference ranges as guides, and so whether it is twice normal, twice the limit of normal, three times upper limit of normal is important than it being just above the line. Okay. Abnormal results demand confirmation before action. So if you have an abnormal report which you did not expect, make sure that you use the same test again or use other tests and make sure that you are clear about what you are seeing. Lab reports flag statistics and clinicians should find the meaning in that. Sounds dramatic, but my point is when you order a test, make sure in your own mind what result you are going to expect. Most of the time you will be right. You may even say it may come positive or negative. Which one is more likely? If you say yes, then it's fine. And if it doesn't fit it, check for pre-analytical errors, check for analytical errors, check for interpretation, and finally check your own clinical examination history and diagnosis. Because it is possible that we may have overlooked something and hence this is not the expected result that we got. So whenever you are in doubt, reevaluate first the lab, reevaluate yourself, and before you over investigate or over treat. So always aim should be to test, to send the right test at the right time for the right reason and do the right interpretation. Thank you very much for your patient hearing. Over to you, Dr. Sanika.
Thank you so much, sir, for your presentation. We have a couple of questions that have come in during the session.
Sure.
Yes. Uh, Start with, does high reticulocytes reflect in the form of increased TLC in the lab report?
Yeah, that's exactly what I tried to emphasize on the report on the case that I put it for thalassemia. And the good part of the story is that the newer machines are better trained and they do not make the mistake, because they can not only segregate the different types of white blood cells, but they can also identify blast cells and they can identify the nucleated RBCs as well. So this used to be very common earlier, but with newer machines, that as well as the high platelet problem is much lesser now.
Yes. So Dr. Krishna is asking, standard lab tests are costly and most cannot afford, but the local labs are cheap and use sync tests. How do we truly confirm which lab is right?
One is you can visit the lab, so you know whether it's a sync lab or a non-sync lab. So remember, sync lab will sync you and the sync the patient. So if you have any doubt at all, please stay away from that lab. How do you make sure the labs are standard or not? Of course, I mean, they would have accreditation and all that, but we know that if it's a sync lab, it will print that it is accredited and you will not know that. If your reports are consistent and you can talk with your pathologist, these are the two things most important, more important than any stamp of the degree or the report that comes on the paper.
Next question is, what are your insights on the bedside tests that we do?
So currently, when you say bedside test, meaning if you are saying the only bedside test that typically we do is do a urine dipstick. And when I'm saying bedside, I'm trying to say clinic bedside, because in the hospital today there is nothing bedside, because only the whole lab is bedside. So you can get everything done in a jiffy when you want it urgently. But otherwise, blood sugar and that is hemostics and heuristics are the two tests that one would say you would be doing bedside. And that's where you need to be very careful about how you're going to interpret and what are the restrictions for that. That actually has a lot of discussion on false positive, false negatives of various parameters of heuristic. And I thought that I would just touch upon saying that you have to be careful. That's all.
Yes.
Like for example, if you are doing a heuristic and the leukocyte esterase comes negative, that does not mean that there is no UTI. There could be an organism which is not working for leukocyte esterase. Or say for example nitrites on a heuristic. Nitrites, the urine in children doesn't stay in the bladder long enough for the bacteria to generate enough nitrites for one to get it on the heuristic. For adults, when you do in the morning, the urine has been in the bladder for a long period of time and there are enough nitrates to be picked up. So if you don't get it positive, does not necessarily mean that you're looking something else. Most important is you have to have clinical judgment, and labs are only supportive.
So, Dr. Samir has asked how to rely on a blood culture report showing staph hominis positive, but by the time the culture report is here, the patient is febrile.
So it depends on what you have been giving. So many staffs, I am not really sure about the particular staph hominis, but if it is one of the routine skin flora like staph epidermis, I would not worry too much and treat this as a contamination and be happy with it. On the other hand, if it is an organism which is bothersome, but the child has become afebrile, then probably it means that my antibiotic, what I have started, is working. Because there is a school of thought which says if you have sent a blood culture, you are suspecting a bacterial infection. And so it is imperative for you to start an empirical antibiotic after sending the culture. There are very few situations where you will send a blood culture and not start an antibiotic.
So Dr. Nehal Shah has asked how accurate are bedside bilirubinometer readings when treating an infant with high UC jaundice on PT phototherapy.
Yeah, again, I would use them for serial monitoring and not for the first report. and also in a sick child I would be reluctant to use, where few milligrams are going to be important for me. I know this is a bit of a vague answer, Dr. Nehal, but that is exactly what I would be doing. I would not hesitate in getting a good blood sample if it's going to be a critical decision making range for phototherapy versus exchange transfusion. But if I have a child who is, say, day 3, day 4, I'm thinking whether it'll require phototherapy or not, then I've done one sample. Next day, the third day, I can monitor with skin bilirubinometer and manage with that.
Yes. So Dr. Gopal has asked how to suspect septicemia in the first week in a newborn.
First week of life, if it's first week of life, it's very easy. Any child who has fever, who does not look dehydrated, or who is not been over swaddled, that means you keep the child open for a while and make sure that child is feeding well, passing urine more than 6 times, is not tachypnic, is not cyanosed, is otherwise looking good, then fine. Anything other than that, any febrile neonate is to be treated as septicemic till proved otherwise.
Yes, sir. They haven't mentioned if it is first week of life or first week of like first
So
since
I
the
will
first.
answer the other way around. So if it is not a first week of life, but it is first week of fever, then septicemia would be on basis of overall clinical condition. So you will be looking at SIRS, whether there is systemic inflammatory response or not, and whether the WBC count. There are many scores available and patterns available, but generally one would think of septicemia in without any risk factors in first week of fever when the child is very sick. If there is a cardiopulmonary, there is a cardiac trauma, there is high fever, WBC count more than 20,000, predominantly polymorphic, CRP is high, etc.
Yes. We have a couple of more questions, sir. Uh,
Sure.
PCT testing and how do you interpret low CRP in an early phase of serious infection?
So two questions. PCT testing extremely expensive. So I personally feel no role in OPD practice and very little role in ward practice. For rheumatologists, it's a double-edged weapon. Many people use it for diagnosing as one of the parameters for Kawasaki, but it's fraught with danger. So you need to be understanding PCT very well if you're using it to diagnose Kawasaki. Using PCT for sick patients in the ICU, very good test, early to pick up, and majority of the time it reflects bacterial infection. How to interpret low CRP in early phase of serious infection? If it is in first 12 to 24 hours, then CRP may be low, but beyond that, CRP will be elevated. And other than conditions like, as I said, SLE or some rare congenital complement disorders, you will get CRP elevation in most of the serious conditions, serious infections, sorry.
Yes. Uh, Dr. Trishna has asked, how do you differentiate stress leukocytosis from early infection in children?
So that's a very good question. And when you say stress, what is the stress due to? The stress is due to fever, stress is due to seizures, stress is due to fasting. What is the stress due to? Or the stress is due to the early infection. That is the critical point. So if all the other three are not in picture, meaning the fever has not been significant, and there has been no seizures, and the child is taking feeds accurately, and there is leukocytosis, then I would be more careful in labeling it not as stress. The point here I'm trying to make is whenever you have leukocytosis early in infection, first of all, one would not have done the test early in infection for WBC count. If you did that and the child is relatively stable, you have time to repeat it again after 24 to 36 hours and not jump to make a diagnosis. If the child was sick, then take it as leukocytosis because of infection, because stress will not make the child sick. Sick, when I say sick meaning high fever, dehydrated, tachypnic, etc., acidotic, etc. So look for other signs and symptoms of infection, any localizing signs for infection. That is how you will differentiate. The classic situation that we see is when a viral fever leads to febrile seizure. The patient comes and you get the CBC count done, and that comes 15,000, 17,000, and one would start thinking whether this is bacterial meningitis or febrile seizure with viral infection. So that is where the most likely situation is to use this as a stress leukocytosis if there are no other signs of bacterial meningitis.
Sir, I think this is the last question, is when to test precalcitonin?
Yeah, I think I just answered that. I'll repeat it for the sake of it. I would test it only when a serious infection or in a critical child, in NSU or PSU. Cost, meaning the word I use is if available and affordable. It's a good test to use, but there are options available where you can go do without it and use it only when other tests fail, simply because of the cost.
Yes. Sir, I think
Thank you so much.
that brings us to the end of question and answer session as well. If there are any more questions, you can write them in the comment section now or later, and I can ask sir on your behalf and get them answered. Thank you so much, sir,
Sure.
once again for your presentation and answering all our questions.
Thank you very much. Thank you so much.